Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm your host, Leo Arguelles, and in today's episode, our guest is Danny Young. Danny is one of our new co-hosts on the podcast, and he is an associate professor at the University of Nevada, Las Vegas. On today's episode, we discuss how the university inspired him to consider physical therapy as a profession. We also discuss his journey from PT school through academia and where his research is now heading. We hope you enjoy the show. Welcome to Acute Conversations, the official podcast of APTA Acute Care. Today's guest is one of our new co-hosts, Danny Young. And I wanted to just record this episode to give him an opportunity. You've heard him already in a previous episode, but I wanted to give Danny an opportunity to maybe give him a chance to talk about himself and his journey and how he has found himself, first of all, as a PT, as an acute care PT and researcher, and also at UNLV, which you're at, and now as a co-host. So Danny, welcome to the show.
Thanks for having me, Leo. I appreciate the opportunity to talk about myself, because who doesn't love talking about themselves?
Of course. So let me start off just with your origin story. How did you eventually end up in the field, the profession of physical therapy?
Yeah, I've always been interested in the sciences and the health sciences in particular, all the way back into elementary school. Loved my science classes. And so I knew I was going to do something in that area. But I had an experience. I was visiting a friend, so a woman with multiple sclerosis, and she had a full-time caregiver who helped her do all of her personal things. She was kind of a personal attendant that was there. And I was over at this woman's house. We had dinner. We went into the living room. We're going to watch a movie. There was a few of us there. And this caregiver was helping this woman from her wheelchair to get onto a blanket so she could just kind of stretch out and be more comfortable while I watched this movie. And as I watched that happen, it was one of those moments in life where, it feels like a ray of light just kind of comes from the universe straight into your mind. Right. And I was like, I need to be a physical therapist. And so, yeah, that was the moment when I said, I'm going to be a PT. And for a long time, I imagined being an outpatient neurotherapist.
Interesting.
Yeah, all through the time that I was thinking about going into school, finishing prereqs in undergrad and applying, going through school, going on my clinical rotations, I'm going to be an outpatient neurotherapist. And the job that I had lined up to do that when I was getting ready to graduate kind of fell apart. It turned out to be good, because one of the sites where I'd done a clinical rotation was in a hospital, and the manager, the rehab director, it's a woman in Omaha whose name is Natalie Harms. She was one of my faculty at Creighton. She taught like our business stuff, and she was the rehab director for Creighton University Medical Center, inpatient and outpatient. And she really liked me, and she's like, I'd love to have you work for me when you graduate. And I was like, yeah, I'm going back west, where I have family and friends, and I'm going to be an outpatient neurotherapist. And she was like, well, if you change your mind, there's a place for you here at Creighton. And so when that job fell through, I'm like, hey, Natalie, are you still interested in having me come? She's like, yes. Cool. She's like, I know you want to be an outpatient neurotherapist because you've told me, but I really think that we have got to start seeing patients in intensive care. And I was graduating in 2002. So I went to Creighton when DPT programs were new. So I started in 1999 and graduated in 2002. And so intensive care wasn't a place where therapists were seeing patients routinely.
Really?
But Natalie was convinced that we needed to. And so she's like, you're the guy. You can go down and you can make this happen. So get down in the intensive care unit and do whatever you need to help those patients. And I loved it. I loved being down there. The confidence that she gave me, even as a new grad, to go into that environment and to try and figure out what I could do to help those patients was really awesome. I loved it. But I wanted to be an outpatient neurotherapist. And so she true to her word, she gave me time. We built a new clinic in South Omaha, an outpatient clinic, right in an office building with a neuro clinic in it for Creighton. And so I got to do some marketing with those physicians, started seeing patients 2 days a week in the outpatient clinic there. And it was the worst. I hated it. It was so terrible. I'm like,
sorry, outpatient neurotherapists that might be listening to Review of the Moonlight, but
I try to tell my students, despite how lame and boring I think lots of different parts of practice are, I'm so glad that you're doing it, because I just couldn't. Like, I hated it. But we definitely need outpatient neurotherapists and outpatient orthotherapists. But man, it was not the place for me. I just dreaded going down there every Tuesday and Thursday. I was like, oh, can I just go back to the hospital, please? So that was how I ended up, working in the hospital. And for 5 years, I worked at Creighton University Medical Center, other than, these few months where I had to go on Tuesdays and Thursdays.
The dreaded Tuesday, Thursdays, and outpatient.
I was inpatient the rest of the time.
Wow. So going back to when you had that experience first, when the universe kind of planted the seed in your brain, how old were you? Were you high school, undergrad?
No, I was in undergrad. So I was in college. I was 21, 22. So it was before I had really picked a major. I had gone to undergrad for a year, and then I was like not sure what I wanted to do. So I had taken some years off, and I was working and pursuing some volunteer and service activities and things like that. And just trying to figure out exactly what I wanted to do in life with career. And that's when that hit me.
I think that's so interesting how sometimes maybe us as therapists, we don't realize the impact that we have on not only patients, but maybe some of the people that might witness some of our treatment sessions, or maybe that just discussion, or maybe even it's outside of patient care. Maybe it's just something that, the different ways that we can have an influence on people. And sure enough, maybe we're the ones that somebody might just witness a short sentence or a treatment session and say, wow, I want to be able to do that. Now, so you went into PT school already with this idea of going the neuro route. Tell me a little bit about your clinical rotations. Do you remember where your clinicals were at?
Oh, sure. How can you forget those kinds of things?
Right.
I did a couple of, we had 6 clinicals at Creighton, 3 short ones and 3 long ones. And my 3 short ones, I knew I didn't want to do outpatient orthopedic stuff. And there weren't any outpatient neuro specific clinical rotations that we had. And so I tried to set one up and it fell through. So I did outpatient ortho for my short rotations at the beginning, those 3 that were kind of in the middle of coursework. And then for the last year, when we had 3 long clinicals, I did 2 sniffs and a phase 1 cardiac rehab that was in a hospital. So it was acute care. It was just focused on cardiac patients. So I was seeing people after heart surgeries and heart attacks and that kind of stuff. So,
so so what was it about the outpatient population that was so different compared to inpatient? Was it just, you had just found your home in the acuity? Because the other thing that you had mentioned is that they were right away putting you in the ICU.
Yeah.
I feel like some of my new grads that are working in acute care, they might have had like some experience, some exposure on the rotations. But from when I remember, when you have a new grad that would start at the hospital that I worked at, sometimes we would start them in maybe a general medical floor and slowly kind of wean them up until they're ready. And there were some that had different experiences that had a lot of acute care experience in ICU, and they were a little bit more fast tracked.
Right.
Yeah.
Well, the phase 1 cardiac rehab rotation that I had done included time in the intensive care unit. And I did that rotation at Creighton University Medical Center where Natalie hired me. So I'd been in that, it was the same intensive care unit. It was a trauma surgery ICU. So the cardiothoracic surgeries patients were in there. I had been in there. I had seen them. I knew the nurses. I knew the cardiac physicians that were there. And she's like, I have a lot of confidence that you can, if you can see those cardiac patients, you can see the trauma patients and the general surgery patients, whoever else is down there. So I think that gave me some advantage when it comes to exposure. I had a great clinical instructor. It was a guy named Rod Sink. I was just trying to look him up too, because, he wasn't a young man when I was his student. He'd been practicing for 15 or 20 years by the time I was his student in, 2001, when I was or 2002 when I was his student. And so he wasn't a young man then. He's definitely not, but man, he was so good as a CI. And he had high expectations, but he really thought a lot about his role as a clinical instructor and how to build on experience and how to titrate that for the student so that could do things that would grow confidence and competency at the same time. Just loved that clinical rotation and what he taught me about being a clinical instructor and about caring for patients in that setting.
That's so interesting. I was just thinking about that because my first year students have completed their first 3 semesters. So the first 2 semesters, they had a summer semester, and then they go on in their first short clinical. It's just a 2-week clinical. And so grades were due today. And so I was just kind of, the past couple of days, I've been reading a lot of their reflections, and you can tell the students that had really influential clinical instructors, clinical instructors that were intentional about their learning, intentional about building their confidence, and then also reassuring them time and time again after reading the reflections. I think it was reassuring for the students to know that they don't know everything, and that's okay. They're right where they're supposed to be for their first clinical within their first year. But I've also had, I've read a couple of reflections where the clinical instructors were maybe not as, I guess, prepared or as giving with their knowledge. And just thinking about that with your experience with a good clinical instructor that is very intentional about building up that confidence. And that's another thing that's interesting you brought up is in terms of building that confidence. Where do you think that comes from? Because I have a lot of students that feel like I'm not confident, and sometimes the trigger responses, well, with time, with more experience. But I also feel that maybe just is a blanket kind of response. I wonder if there's a way we can hash that out. So what helps build confidence in so I think about my previous clinicals and with your experience with both students and also as a clinical instructor and working in the clinic, where do you feel that confidence comes from?
Well, I think that the lack of confidence is a reflection most often of just some humility that the students have. And so I try to reassure students that it's a good thing that they feel a little bit hesitant and unsure of themselves, that it's a recognition of the things that they don't know. So I just first want to acknowledge that not feeling confident is okay, and is actually something that's probably reflects some good attributes. Because I don't know about you, Leo, but with students, it's not lots of them, but I've had a few over the years who they have no lack of confidence, and it's usually a problem because they're blind to their ignorance. They don't recognize what they don't know. And so I think having a little humility is helpful. And the problem is that many of these folks are paralyzed with that humility. It's so overwhelming to them that they don't recognize what they do know. And what Rod did for me and what I try to do for my students, like I said, is that he titrated the experience to help me to grow. So he gave me a baseline exam. Like I show up day 1 of my clinical, he's got a written test for me. No way. Rhythm strips printed out from real patients, and I have to look at them and identify rhythms, medications and the effects of those medications, a bunch of that kind of stuff, education things for patients about activity after heart surgery or heart attack. He gave me a test, and I did terrible on it. And so what he said to me is, look, I expect that you don't know all of these things because there's not time in the curriculum for you to get them all, but you're going to learn those with me while you're here. And so he let me practice some things on him. He let me practice taking blood pressure on him while we were standing and or moving. And he gave me good feedback and instruction on that technique. He brought me in and let me watch what he said to patients. And then he did a good job of quizzing me right after we did that on things that I observed and that he wanted me to learn. And so providing an example with asking me questions and then giving me opportunities to demonstrate those skills that he had just demonstrated that I had practiced, giving me opportunities to do those and checking in with me frequently. How are you feeling about this? How ready do you feel to do that? And sometimes he had to hold me back and to point out to me that, you're probably not quite ready to see these patients who've just had myocardial infarcts because your ability to recognize changes in rhythm and vitals while exercising is still developing. And he then would force me to confront my ignorance if I was overconfident. And so he just did a good job of being very aware of where I was. And so I've tried to do that with my students, to be excited for them, to not be overly critical, but to not be afraid to give them feedback about where they're at, and to let them know that I'm here to help them to grow from wherever they're starting.
That's great. Having that specificity. It's just like an excellent therapist, right? Just giving the right amount of difficulty, right? So that the patient can kind of rise to that occasion. And if you do too much, if you overdose or underdose, it can be problematic.
That's right.
That's the thing I think within the research that's been growing more and more. We have more and more literature just looking at that, which reminds me. So after you had started working as a staff therapist, how long were you working as a staff therapist? And then when did you start moving into academia?
So I spent 5 years at Creighton University Medical Center full-time as a therapist. I did some things with being a lead in the department and working on some different committees or things, but primarily I was seeing patients full-time for 5 years. And one of the things that fairly quickly started to really bother me was the debates that I would have with nurses or physicians. And when I say debates, I would go to a nurse and I would say, hey, I was thinking that, Mary in room 5 is ready to start getting out of bed. And the nurse would be like, oh no, she's way too sick. She's not stable enough to get up. Or I would go to a physician and say, I'd say, Mark in room 7, I really think he could start benefiting, from this type of exercise. Oh no, he's way too sick. Don't do that with him. And I, in my head, I'm thinking, but I think that they could. And I've received such opposition for so many patients about early intervention that I went and did a literature search, because I didn't get any training in school about early intervention. Like I said, it wasn't a common part of practice then. And so I do a literature search and I find nothing. There was no evidence. Now there was evidence that bed rest was bad.
Right.
So we had evidence that staying in bed was a problem. What we didn't have was evidence that it was safe or helpful to start mobilizing those people earlier. And most of the physicians and nurses at that time just assumed that there's no way around the negative effects of bed rest for these people who are really sick. And that was so frustrating to me. And I thought, there's no evidence to inform these decisions that I have to make every day. And that's got to change. And why am I not the person to try and answer those questions? Why am I not the one to try and generate that evidence? And so that's why I started looking for opportunities to get training in research and to be involved in an academic position is with the goal of creating evidence that could inform those clinical decisions in the hospital.
That's an interesting story. Just thinking about that. I don't know why maybe it's my own kind of biases in terms of people that go into research. Like I've had classmates or students that they primarily wanted to go, like from the get-go, from while they're in PT school, they want to go into research, as opposed to starting off as a staff therapist and thinking, you know what, there's a limit in terms of what I can do here. Can I do more in terms of there are these unanswered questions and there's no literature out there? I mean,
I
that initiative.
I never felt like I was doing something that was less or more in either of these capacities. I think that it's critical that we have skilled people who are excited about treating patients and about applying the best information that we have in guiding those clinical choices. And I was just frustrated that I didn't have better guidance, that I didn't have information that I could use to facilitate the discussions with the nurses, with the physicians, with the patients and their families, to say, I know you're sick. I know you're in pain. I know this hurts or is hard, but we've got to do it. I didn't have evidence to say that with authority. And that was just really frustrating. And so I thought, I've got to answer these questions. I've got to work on this. And I'd always been interested in science, scientific thinking, scientific methodology, scientific logic had always appealed to me, and it had always been interesting to me. And so I thought that would be an easy transition. And I talked with some of my mentors when I was thinking about this, and they all of them said, you need to go work on a PhD full time. And if you want to work on answering research questions, that's the route.
Wow.
And so by then I had a wife and 2 kids, and I talked with my wife about this, and she says, I'm fully supportive of this idea that you want to get a PhD and, kind of change career directions. But she said, I'm not going back to being a student's wife. And so you're going to have to figure out how to do this while you still have a job.
Right, exactly.
Which, fair enough. We've got 2 kids we're trying to raise together. And so I thought, man, I don't know that I can do a PhD at the same time as I'm a full-time clinician, because during your day as a clinician, it's not very flexible. Like, how am I going to find time to do that? And honestly, at that time, I think that if I could just get a faculty job, I could figure out the research on the job. Like, I don't think I need a PhD to do the kind of research that I want to do. That was my thinking. And so I looked places that I was interested in. I tried to get Creighton to hire me in their DPT program. I tried to get UNMC. Those are the 2 programs in Omaha where I was living, to hire me. And both of them were like, you don't know what you're doing, like we don't need you. And so, but I was undeterred. Like, I thought I can, they just don't know me. I can figure this out. And so I came to Las Vegas, which is Nevada is home. I went to high school here in Nevada. And so I came back home and introduced myself to the people that were here. There was a Creighton alumni, Merrill Landers, was here on faculty. And so I got introduced to him through some of the Creighton contacts that I had. And they, fortunately for me, lost 3 faculty 1 year.
Wow.
And so in 2007, I came here full time. And at that time, UNLV was kind of a tier 2 research program. The PT program was very focused on clinical instruction and not on research, but they only had tenure track positions. Those were just the only type of faculty jobs. So I get hired into a tenure track position with just a very low research expectation. And I thought, this is awesome. I can, start teaching, which I know I'll enjoy. I was looking forward to that as well. And I'll be able to kind of on the job figure out this research stuff without a lot of high research expectations like I might have at an R1 school. And so it seemed perfect. So I came eager and excited to do it. And man, I was so blind to how hard it would be to make that transition. The teaching was hard enough, and that transition, figuring out how to put a class together and how to evaluate students and give good feedback and manage a group. Like, those were skills that I was able to develop reasonably quickly, but it wasn't trivial. And I worked way more hours during the first 3 years that I was here than I had ever worked in the hospital. In the hospital, they didn't want me doing overtime. Like, come in, put in your hours, and get out of here. That's right. But in the university, they'll let you work as many hours as you want.
Of course,
and so I was working 60 to 80 hours a week, just trying to figure out what I was doing and feeling a lot of pressure to do some research when I was hard to just get my classes figured out. And so at the end of those first 3 years, and those of you who have taught classes, after 3 years, like, okay, if I'm teaching the same classes and I've kind of got my lectures put together and I know what my tests are like, then I started thinking, okay, I've got some bandwidth here. Maybe now it's time to think about the PhD. And so in 2010, in 2010, I started a PhD in public health at night. UNLV had a new Epi and Biostats PhD that they were offering in their School of Public Health. It was on campus. All the courses were going to be in the evening. I thought, I can do this. So I just as I was starting to get a more normal work hour schedule, then I started a PhD and I went right back to 60, 80 hour weeks for a few more years. So that was how I got here in kind of the first few years of my life here. And that's when I published some of those papers that, like, I didn't know what I was doing. I didn't have the relationships that I wanted. The benefit of doing a full-time PhD and then even a postdoc is that you get relationships with people in the area of research that you want to work in. And I came here without any of that. And so, I had allies in the department, but they weren't working on the stuff I wanted to work on. They were working on dumb things like outpatient ortho questions and sports questions and outpatient neuro rehab questions. I didn't care about any of that. I wanted to work on hospital questions. So I was on my own. That was tough.
So talking about some of your early research, I have to share this story because at CSM in Houston, you were, and those are some of my, I think my first memories of you is that usually at CSM, you're also part of our Shark Tank. I think a couple of years ago, I had interviewed you for our Shark Tank.
Yeah.
But this last CSM, I think you said during one of your presentations that like anybody can get published, and in terms of, you know, being in the literature, but you said read some of my early works. It's not that great. And maybe there are a couple other words that you said, but I heard somebody that was in one of the overflow rooms just started cracking up the way you had described reading some of your early work. Now, so what's changed from your early work to the work that you're doing now in terms of you as a researcher, that evolution?
Well, after I finished my PhD, then I realized I really had no idea what I was doing. Up until then, I was optimistic that I was figuring it out, but I just got really slapped in the face during that time that I didn't have the relationships, I didn't have the knowledge to do what I wanted to do to answer the questions that I wanted to. And now I've already been at UNLV for 7 years, and I'm just now realizing that I can't do what I want to do, like the thing that drove me to come here. It was around that time that I was talking with my chair, and he had heard about Linda Resnick's co-star fellowships, and he's like, you should apply for one of those. It sounds like what she's doing, and these fellowships are more like what you're interested in. Maybe that'll help you. And so I applied and didn't get selected, but got some good feedback and applied again and got matched up with Alan Jetty as a primary mentor, a co-star mentor, and got embedded because of Alan's relationships with the Johns Hopkins Activity and Mobility Promotion Group. And so I got embedded within that system, got an appointment at Hopkins in their med school. Dale Needham was on my mentorship team. So it was Alan Jetty at co-star and Dale Needham at Hopkins, and then the AMP leaders, which was Mike Friedman and Eric Hoyer. And that is what really helped me to get the kind of orientation that I would have gotten years earlier if I had done a PhD in a lab where they were doing the work I wanted to do, and a postdoc where they were doing the work I wanted to do. So it wasn't until I really got affiliated with them that I started to gain some of the skills and build some of the relationships that I needed to do what I wanted to do.
Wow, those are some heavy hitters. Just those names that like Jetty and Dale Needham, who was also one of our guest speakers this past CSM, right? That's so great for you to be able to work with them and kind of, you know, pick their brains and develop research. What are you seeing now in terms of the forefront of our research? What are we starting to? Because what I'm seeing in terms of when I'm looking at some different research that's dedicated to acute care is, you know, what are the factors that influence, you know, which patient to see at which time, how early. There's some of those different parameters. Discharge planning is a lot of things that I've been seeing in the literature. Like what are the parameters to help decide discharge planning? What are you seeing in your end in terms of your research and maybe some of your other colleagues that are doing research in acute care?
Yeah, well, I mean, for those of you who have kept up with acute care research, you know that we have some of the strongest evidence now for critical care. And it's folks like Dale, and, you know, that's why he was invited to speak at CSM in Houston, was because he's led a lot of that effort, and he's involved physical therapists in that work and has trained physical therapists to do that with him. So we have good evidence that it's safe to see those people, and that when we do see them, that there are benefits. Unfortunately, we have less evidence for people in the rest of the house. In fact, in many places, and I don't know if you've been to hospitals that are like this, patients in the intensive care units get a lot of therapy, they get mobilized early, and then they go up to a floor and they lay in bed for, you know, the next few days before they go home, and they don't continue that. And it's because we haven't figured out who and what needs to happen for people up on the rest of the wards. And so I see big gaps in our knowledge for lots of patient groups that are in the rest of the hospital. You know, we know that ortho patients need regular therapy. The ortho docs are loud about getting us in. We generally have enough staff to see those folks every day or twice a day after they've had a hip or knee replacement. For the acute neuro patients, for people who've had a stroke in particular, we've got good evidence that early and frequent therapy is helpful for those folks. So we have some populations where we do have some information, and we tend to then divert all of our resources to prioritizing those patients. We see those people first. Then we see any other new evals that come in, and all the other folks get triaged, and we see them when we can.
Right.
And so I think we've got some big gaps in knowing who needs us versus who just needs a better hospital mobility plan to mobilize patients. They don't need therapy. They just need encouragement and permission to move. So who are the patients who we need to see? And at the same time, what can we do to facilitate a hospital-wide culture that encourages patients to be mobile, that facilitates patient mobility? How do we set that up and structure it? And I think the group at Hopkins has done as much or more than anyone in trying to flesh that out. And it's been one of the benefits of me being affiliated with them. But I think on the therapy side, we're even further behind. I think we're starting to make advances in the recognition, with age-friendly health systems and CMS saying that we need to assess mobility, that mobility is one of the key components of appropriate hospital care. I think that there's going to be movement in that direction for these patients who don't need us necessarily, but there's still this tension in hospitals because therapy resources are being allocated to other patients about what do we do then with the person with pneumonia who maybe with more therapy could go home, but because I'm busy seeing ortho and neuro patients, I don't get to them, and they end up in a SNF for a couple of weeks after they leave the hospital. Figuring out how do we target them properly? How do we identify them versus the people who are going to go to a SNF no matter what happens, or the people who are going to go home no matter what happens? There's people who, if we see them, we can make a difference for them, and we're not good at figuring out who they are. So those are the things that I'm spending a lot of time working on. And the other thing that I think we lack a lot of evidence on is cause and effect. There's lots of literature showing associations between therapy and outcomes, a lot of correlation papers. And it's not a bad idea to start with that kind of evidence, but we need to move to the kinds of studies that can show that this therapy intervention causes this patient or system important outcome. And we have very little of that evidence. And so those are areas where I'm trying to push the work forward.
That's so interesting. I still remember sitting in a graduate program in my PT program, just talking about the cause and effect versus correlation. And I always remember the example of the correlation between storks and newborn babies. And so there's a higher correlation. Yeah, there's more storks and more, places that have more babies. But does that mean that it's a cause and effect? And it always stuck out in my head that, maybe it's because more so related to the environment and, where the new homes and younger families with new babies are living as opposed to the cause and the effect. Or I think it was also gun violence and ice cream. So does ice cream create more gun violence? It's like, there's a correlation, but there's cause and effect. But
And as therapists, we're so biased because, if you talk to acute care therapists, they know that their patients need them. They know their patients benefit from their care. And it's easy for us to fool ourselves when we see a study that shows a correlation that we were the cause of those positive changes. And what I've done at the last couple of CSMs is I've given a presentation with a group of folks where we talk about the most recent evidence in acute care. And we get a bunch of articles that talk about how beneficial therapy is. And my job has been to say, we shouldn't be so excited about these studies because the designs aren't very strong. They're correlational studies. There's a lot of confounding here. There's a lot of reasons that these outcomes could have happened besides therapy. And it's not because I don't want therapy to be, the answer. It's just because I think it's so easy to fool ourselves when, we're drinking our own Kool-Aid, and it's like, we need evidence because we've got to convince payers. We've got to convince doctors. We've got to convince nurses, and we're not going to do that with low quality evidence.
Right. Which, again, over at CSM in Houston last year, it was just somebody would talk about this evidence, and then whenever you would come up, everyone's like, "Uh-oh, what's he gonna say?" It's like you're like Dr. Doom coming through, and just Mr. Everyone's up here. Oh, there's this great correlation because great things are happening in therapy, and then whoever the speaker was would come off the mic, and you would come. Everyone would just go,
because they knew.
But what I think what's good is that it's such a good lens in which to critique us, right, as a profession. Because if we're just going to say that, everything is great, there's this correlation, it's like, no, let's from our detractors, for people that are going to say that therapy is not beneficial, they're going to use that argument. So let's be prepared and just internally, let's go ahead and critique. And I think that's how we start to get the best outcomes, right? I mean, it's when you've got those that are really closest to you that'll say, hey, this is, they're going to really critique you and give you the reality check of what needs to be done, what needs to be improved, because they know it can be better.
That's right. Yeah, that's exactly right. So I try not to throw too much cold water on people's enthusiasm. I try to encourage positive thinking and people with energy and desires to help patients and do good work. And at the same time, I try to help us to be realistic about what we know and what we don't know, and what we need to do to move towards better knowledge so that our practice can be the best it can be. Because everybody goes into healthcare because they want to help patients be better. They want to do the best for their patients. And we get caught up in productivity standards and, whatever else, with staffing and scheduling issues and CEO bonuses that, make us feel screwed when our partner just got their pay cut or furloughed. Like, we've got all these other things that are going on that distract us from trying to provide excellent care. And so I hope to move us in that direction. Those are my goals. That's why I was motivated to come and, take this position and suffer through the pain of learning how to write grants and to write manuscripts and, sit in an office where I don't get to walk around and talk to patients and visit. I loved being in the hospital. I'm up moving all day, talking to people. It was fantastic. And now I sit in an office and I stare at a computer most of the time. And why would I torture myself like that? It's because I think we've got to have better evidence, and I'm committed to trying to help to create it.
Well, thank you, Danny, for being part of the podcast. And one last question. So what motivated you to interview for the co-host position?
Well, I'm tired of staring at spreadsheets in my office. And I'm like, I need to talk to real people and do something more interesting. And
That's
so
great.
I had listened to the podcast. I love your energy. I feel like the side of me that is enthusiastic about acute care doesn't come out enough because I end up being the Debbie Downer on all the presentations.
Everyone just sees you at CSM just critiquing, picking everyone's like, man, that Danny guy. I don't want to talk. I don't want to sit with him at the lunch table. He's going to critique me.
I want people to know I'm not like that all the time. That I can be a cheerleader too, and I can have a good time with you. So.
Absolutely. Well, we appreciate you being part of the podcast and the energy that you're bringing and kind of your different lens to be able to view things. So thank you for being part of the team.
I'm excited to do it, Leo. Thanks for giving me a chance. And I hope that the guests we bring on, the conversations that I try to facilitate, will be helpful to the audience.
Very cool. I will say that Morgan, who is the outgoing practice committee chair, she's a grad from your program.
UNLV.
When she heard that, when she heard that you were going to be in the podcast, she was pretty excited. She's going to be a great addition to the team.
Oh, that's such a nice endorsement. Some of the students, some students love you and some students hate you, and you treat them all the same. Like, I try to be good to the students. I try to help them, and you connect with some and you don't connect with others. So I'm glad that Morgan had a good experience.
Yeah. I always feel funny though, like years down the line when you might hear like a student's like, oh, they had a really, and you're like, wow, they were really quiet. And like, I had no idea.
I didn't know.
The influence that I had on that student. And like, I haven't seen you since graduation. Oh, I'm working in acute care. I'm working because of some of your stories. I'm like, I said that? That sounds really cool. I didn't know if I said that. I probably stole that from someone else, from Danny Young or
that's right. Exactly.
Danny, I think it's time. We're gonna play our rapid responses. I'll only time it for a minute, but we're gonna do something. We're gonna shake it up a little bit because we're gonna go back and forth. So it's not only Danny answering the questions. I will ask a question.
Okay.
And then you will answer it and then give me a question back.
Okay.
I haven't done this side. And we'll time this for maybe about a minute, give or take. Okay. All right. Danny, you ready?
Mm-hmm.
All right. Let's get started. First question I'll ask is, are you an Apple guy or Android?
I am an Android guy. I have an Apple computer. I love my Mac computer, but I got mad at Apple for their iPhone sandboxing and the limitations that I got. And so I try to convert people to Android phones whenever I can.
Ooh, nice. Good answer. All right.
Are you if you're going to pick a movie, is it going to be a comedy or a rom-com?
Oh, those are both good. Depends. If I'm going to watch by myself, definitely a comedy, especially if I can laugh at a movie by myself, then it was a really funny movie.
That's great.
What's your most favorite way to exercise, Danny?
I commute by bike. I spend between 2 and 2.5 hours every day riding a bike to and from the campus here.
Okay.
And I love mountain biking as well. So commuting is how I get most of my fitness. But every time I can get out on the dirt trails, I do that too.
That sounds amazing.
Okay, so Leo, what do you do when you're not interviewing people on the podcast and torturing grad students?
For my next part-time job that I'm engaging in right now is I'm a chauffeur for my children, because I have some young children, one that's going to be a freshman, one in 8th grade and one in 5th grade. And so I'm doing a lot of driving around, so I'm putting miles on my car. But other than that, I also like working out. I do Brazilian Jiu-Jitsu, Muay Thai, boxing.
Cool.
So those are some of my ways for me to relieve stress.
I'm
not frustrated with my children.
In high school, I played basketball, but I wanted to wrestle but it was in the same season, so I couldn't do both. But I would, after basketball practice, I would sneak into the wrestling room because I really wanted to be a good wrestler. So I always thought it would be cool to join a jiu-jitsu gym.
What's funny too is that sometimes the basketball players and the wrestlers would they'd put the mats out in the gym, and it was like a hybrid of takedowns on the mat, but then regular basketball by the hoops.
I love it.
Last question, Danny. You're on acute care when, complete that sentence.
You wear different clothes home than you wore when you went in. You
Absolutely.
have to change during the day.
Absolutely. Yeah. I've learned that again, just kind of like, I really don't want to walk in the door wearing these scrubs. We're going to have to go into the mud room and get rid of this, or leave it at work. And then every couple of days, leave those scrubs or change those scrubs.
That's right. That's exactly
awesome.
Right. Do I get one more with you, or is that the end?
Sure. If you want one more question, go for it.
All right. In the hospital, is it better to go to the ICU, med surge, or ortho units?
That's a great question. For me personally, I like the ICU just because the ratio of the nurses and patients, there's the ratio is a little bit better. Maybe it's like 2 patients to 1 nurse or 1. And just because of my affinity for the ICU, I'm closest with those nurses. Yeah. And so I feel like I some of the best treatment sessions that I've had are in those situations where you're literally walking that fence of really, really sick patients. And you're like, and sometimes it goes sideways. You're like, ooh, we thought it was going to go better, but that was a rough one. Mm-hmm. But sometimes you're like, wow. And then the coolest part is when a family member or maybe the surgeon or the doc comes by, like, wow, he's standing, or wow, he was actually able to do it. And the patients. So I say definitely the ICU, just because of my personal experience of some of the great things I've witnessed. But I've seen great things all over the hospital. But my ICU nurses at the different places I work at, shout out to them.
It's okay to have favorites, Leo.
Absolutely. Awesome. Danny, so if people were interested in your story and want to have questions for you, want to hear more from you outside of the podcast, how might people reach out to you?
You're welcome to email me. When you're a faculty member, your contact information is easy to find. In fact, I put my cell phone number on my faculty webpage. So if you just Google Daniel Young and UNLV, you can find me easily. Feel free to email me. I'm on social media, but mostly I use those for personal use. The only one I have stuff for work on is X or Bluesky, and so you can find me on those platforms as well. But if you really have questions, reach out to me by phone or email.
We'll put that in the show notes.
Great.
Awesome. Danny, appreciate your time. Thank you so much. And then we'll see you on the next episode with our next guest.
Sounds good. I can't wait, Leo.
Awesome. Take care, Danny.
See ya.
We would like to thank Danny for joining us today on the podcast and joining our podcast team. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Arguelles, executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for a conversation with our other new co-host, Nicole Naveau. Thank you for listening, and may your shoes and scrubs stay clean today.